evening, everybody, and good morning, Dr. Wendy. Welcome you to this webinar hosted by HaystackAnalytics. My name is Dr. Aparna Bhanushali, and I will be the moderator for this session. I am a Director of Medical Genetics at HaystackAnalytics. At HaystackAnalytics, we collaborate with academic institutions and clinicians to strengthen the translational genomics and the diagnostic interpretation. These are our collaborators, and our journey has been, we've strengthened the infectious domain as well as the rare disorders domain. And today's session is an effort in that direction to involve with the global thought leaders and strengthen the diagnostic, as well as responsibly strengthen the diagnostic framework. So with that, I would introduce our speaker for today, Dr. Wendy Chung. Dr. Wendy is a clinical and molecular geneticist. She's a national leader in ethical, legal, and social implications of human genomics. She directs NIH-funded research across autism, congenital disorders, cardiopulmonary genetics, and metabolic diseases. She has identified the genetic basis of more than 60 rare diseases and is leading the Guardian study to expand newborn screening through genomic approaches. Dr. Chung is a member of the National Academy of Medicine and a recipient of the National Organization of Rare Disorders Rare Impact Award. So we know that newborn screening is one of the most impactful public health interventions, which helps in diagnosis as well as changing the outcomes for lifelong outcomes in neonates. So with that, over to Dr. Chung. But before I do, just a few housekeeping rules. All of the participants are muted. Request you to put your questions in the Q&A section, and we will get back to them as time permits. Thank you. Over to you, Dr. Chung.
Thank you. I'm very pleased to be with you today. Can I share my screen? Yes, okay. Let's see. Okay, hopefully you're seeing the full screen. So thank you for the kind introduction and for having me with you today. I'm going to be speaking about a study we've been doing now for a little over 3 years called Guardian, Genomic Uniform Screening Against Rare Diseases in All Newborns. My disclosures are that this work is funded with in-kind contributions from Illumina and GeneDx to do the genetic sequencing and testing. This is within the context, and I think about this especially with this month, within the context of rare genetic diseases. There are currently over 7,000 and counting. And in my career, as I've been someone working on discovering, understanding, and treating rare diseases, I have to say I've been thinking about their infrastructure that can help across rare diseases to be able to improve the lives of those patients and their families. And what I'm going to talk about today is in part foundational, I think, to that future state for these individuals. In particular, as a pediatrician, obviously all of these are conditions people are born with, but this disproportionately affects children, as many of them actually don't live to be adults. And although they're individually rare, they're collectively quite common. And so in thinking about the public, or in thinking about our healthcare systems around the world, thinking about what are common points where people pass through that system and how to be able to use those systems to help care has landed me on thinking more and more about using genomic newborn screening as a possible way to identify individuals uniformly and collectively and be able to do it quite efficiently and at a time where people can maximally benefit from that information. So I actually started my career working on phenylketonuria, and so for me, this was sort of naturally, I've been thinking about it for about 35 years, but it became much more feasible to think about doing this from a genetic point of view as we were studying spinal muscular atrophy. So, with the Pediatric Neuromuscular Research Network, we had been studying SMA, and we understood the condition to be obviously a degenerative condition of the motor neurons. And within this, we're better able to characterize the actual natural history and the time course for the loss of those motor neurons. As many of you know, this is a very common condition, a recessive condition present in about 1 in 10,000 births around the world. So it's really, although it's a recessive condition, we see it across all ancestries, and babies with type 1 SMA, the most severe type of SMA, often don't live till their first birthday. And so when we were looking at how this is diagnosed in the United States, many of those babies, especially with type 1, aren't diagnosed or weren't diagnosed, I should say, past tense, until their symptoms presented and they made it through the medical system, and that oftentimes wasn't until at least 6 months of age. And understanding the natural history, that was beyond the window when we thought we were going to be able to really effectively treat the condition because those motor neurons were lost. And so as we were thinking about this and seeing treatments starting to get ready to enter clinical trials, I started to be concerned that we would not have a way to be able to effectively identify the children, the infants that would benefit maximally from that. At this point, this was an oligonucleotide, an ASO, to benefit. And so I wondered, should we think about using the public health newborn screening system, given the unique features of SMA being 95% due to exon 7 deletions of SMN1, and being able to design a very efficient genotyping assay that could use the Guthrie cards, the newborn screen cards, to diagnose those children at birth, essentially within the first week of life, to then offer them the opportunity in a consented research study to use the ASO that was going to be in clinical trials. And so this was a hypothesis. This was, again, a consented research study, but timed very specifically for children to have an option for treatment when we knew the natural history would otherwise, at least for children with one or two copies of SMN2, to have a lethal condition otherwise. And so we did that in New York State, where I was at the time, proved that we could do this quite efficiently and effectively, that parents wanted this. 93% of parents wanted to have that screening. And in fact, identified children and within the first week of life could offer them this ASO. This is the first of those children who was in that clinical trial and one of the best responders in that New England Journal of Medicine paper showing the outcomes. And she would have had type 1 SMA. She has 2 copies of SMN2, but instead, within the first 2 weeks of life, started her ASO treatment. And these are her home videos showing her walking at 14 months of age. And she continues to be strong, normal, has not had any respiratory insufficiency, no weakness, no need for ventilatory support, none of the things we're used to with type 1 SMA. And in fact, she started, and her cohort of individuals treated started a ping pong back and forth with remarkable speed. And what I mean by that is then with the data from that clinical trial that led to my Christmas present that year, which was FDA approval for that ASO. With the ASO in hand that was FDA approved, and with the evidence from the pilot newborn screening study, we added SMA to the recommended universal screening panel. And in partnership with Cure SMA, the family group, family advocacy group in the United States, were able to very quickly implement, not only pass the recommendation for screening, but actually implement SMA screening around the country, around the United States, and have now not only one FDA-approved treatment, but as many of you know, 3 FDA-approved treatments for FDA, or rather for SMA, that include an oligonucleotide, a one-and-done gene therapy, as well as risdiplam, an oral agent. And so this has really completely changed the face of SMA for patients not only here in the United States, but really patients around the world. It is still, I will admit, an expensive medication or medications, rather suite of medications. But part of my hope is that we'll also be able to bring the cost of treatments for SMA as well as other conditions down as we gain experience, manufacturing capacity for these, and so that we'll be able to bring treatments to everyone really around the world as we think about this. So in appreciating the success of this, my next question became what other conditions would be like SMA? What other conditions would be amenable to treatments and intervention? And in the same way that I think the screening catalyzed being able to develop treatments and get treatments approved, to me, it's that same paradigm. Can this infrastructure of genomic screening catalyze the development of treatments for other rare diseases? And I do think these things go hand in hand. So I think it's important to think of it as a system, number one. So it's not just a screening test, but it's a whole system of care. And then it's also obviously with treatments that are available. But hopefully, this is something that other things can benefit from. So we went back to families that were in the SMA newborn screening study, not the families who had a child who screened positive, but rather the parents of children who screened negative. So the ones who got normal results, and started a series of conversations with them, asking them basically, what else would you want to be screened for? What else would you want your child screened for if we could? Then we started, thinking and brainstorming back and forth with focus groups and one-on-ones to understand what would they want the study design to be if we started pilot studies for other conditions. And the Guardian study is really designed by them, by those parents. And let me describe what they ultimately helped us arrive at. So the fundamental thinking behind this was that, number one, they very much valued that this could be done on the same dried blood spot that was used for their newborn screening studies, so that required no additional pricks rather of their baby, no additional sort of logistics to go through. And they very much wanted this to focus on what I'll call news you can use, information where there was a treatment available, where this could, prevent harm. And especially, though, they wanted to know about things of immediate concern. Obviously, so basically, to give you the short, if you think about the Wilson and Younger criteria for what to include in newborn screening, they reinforced those same criteria. But I'll give you a sort of spin on this, is they did have some differing opinions on actionability, what was acceptable for actionability, and broaden the scope in terms of thinking about that. So within this, they realized that within doing this, though, this was potentially broader in scope than what we do currently for traditional newborn screening. And so we arrived at several conclusions. Number one is that this obviously should be a consented research study, but they found it helpful because many of them didn't really understand regular newborn screening. They found it helpful to start learning about this while they were pregnant in the 3rd trimester. This would be much larger in scope. And so being able to think about it at a time things weren't so crazy would be helpful. And so we ultimately designed an insert to go into the packet that they receive in preparing for delivery when they're thinking about learning how to breastfeed, epidurals, delivery plans, putting that in their packet so they could start thinking about it then. But we realized that we would want to talk with them and allow opportunities for them to ask questions. So we designed to have in-person research coordinators go to the bedside postpartum before discharge from the hospital to talk with them and answer their questions about the study. Within that, though, we gave them up to 30 days after birth of their baby to make a decision. So if they wanted some time to talk with family members, they could. And we designed this as whole genome sequencing to be able to give us flexibility. when we started this, I'll be honest, we didn't know how easy or difficult it would be to interpret the variants. And so we started out with a relatively limited number of genes, but still 238 genes, so not a small number. But we knew that we might run into challenges with some genes as we put them on the list. We might have to take genes off the list. But more importantly, as new treatments were available, we might want to add genes to the list. And in particular, trying to develop another alternative, for instance, could have been developing a targeted capture panel and having just a targeted number of genes on the list. If we were to do that, validating each time we had a new version of the gene panel could have been prohibitively expensive and time consuming. And so we decided instead to have a flexible platform of whole genome sequencing to give us really infinite flexibility in terms of going back to update the gene list. And we also preserve the data so that if families should want to reinterrogate the data, if their child should become symptomatic later on in life, where they start to have symptoms of something that might not be on that gene list, it gives those families the opportunity to reanalyze the data now in a diagnostic mode and use the full power of the genome. And so there were a number of reasons for the study design to include genome sequencing. Within this, we didn't know exactly how long it would take, so we gave ourselves some a sort of increased breadth of 3 to 6 weeks to return the results. We're now capable of doing this easily within 3 weeks and continue to strive to return the results even sooner. And importantly, also confirm the diagnosis and onboard those children to care. So as we're doing this, let me emphasize that this is a screening test. We do expect to have some false positives as we do with any screening test. So we build into this confirmation of the diagnosis, which includes parental testing. For recessive conditions, we use that as a way to determine phase because this is short read sequencing, and we oftentimes can't determine phase from the short read data alone. In addition, before we start treatment, we have some other orthogonal way of confirming the diagnosis. So this could be an EKG, it could be an enzyme level, but we have some other way of confirming the diagnosis beyond just the sequencing to be sure that we need to treat that child. And as you'll see, some of those treatments can be quite burdensome or quite expensive, or perhaps with some risk associated. So we want to be sure that we're treating the children appropriately. Importantly for this community, as we're talking about this, I started this study in New York City, and as we tried to decide what to include, I did make a conscious decision to include, obviously, pathogenic and likely pathogenic variants, but also to include some variants of uncertain significance, because with this very global community in New York City, I was worried that we wanted to be equitable in terms of not missing children, especially with these treatable conditions. And for people from around the world, many of the truly disease-associated variants are at this point still variants of uncertain significance. And I didn't want to be differentially sort of advantageous to any particular community. We did restrict it though, or we do restrict it to variants of uncertain significance though that are leaning likely pathogenic when we see them in conjunction with another likely pathogenic or pathogenic variant for recessive conditions. So we tried to enrich for the likelihood that these would be diagnostic while not increasing too many false positives along the way. So it's a compromise, but one that we did very intentionally made to try and be equitable. The next question, which is an obvious question, is what conditions do you include? And so the guiding criteria for this, as I said, were to focus on conditions for young children. We operationalize that with the families to conditions that affect children less than 5 years of age. Parents wanted us to focus on conditions that were likely to need action or be symptomatic and likely operationalized to greater than 90%. And so we knew we couldn't be 100%. So we wanted it to be very likely. And as I was alluding to, parents clearly wanted us to include in screening conditions that were treatable, but we ended up with some we didn't have consensus. We didn't have 100% consensus on a group of conditions associated with epilepsy, where certainly recognition and treatment of the epilepsy improves outcomes, but where these conditions might still be associated with other symptoms, symptoms like ADHD or developmental delay or learning disabilities. So we might still have some residual symptoms, but certainly we would improve the outcomes. And as I said, families weren't 100% concordant in terms of their desire for this information, but most of them did consider these to be actionable. So we allowed this as an optional module. People could opt in for this group of optional conditions associated with seizures. So in going through, as I alluded to, for dominant conditions or excellent conditions, we restricted that to pathogenic or likely pathogenic because that's only one allele. And we, again, remember, we don't have parents as we're doing this analysis. This is only based on the baby. But for recessive conditions, we did allow one variant of uncertain significance. So let me show you the data. These are data now on the first 15,000 for whom we have good outcome data as well. We've currently screened 24,000 and are still counting, but I don't have outcome data on all of them because they haven't all sort of grown up, old enough to be able to see the outcomes. We have currently about 73% of families who decide to enroll in the study, so about 3/4. That's not everyone, and that's okay. This is a research study, and not everyone wants to be part of research. About 94% decide to do this prior to discharge, but a few do take more time after discharge, and that's perfectly fine. And in the upper right, you'll see that this is a majority minority population. So although we have about a third who are white in doing this in New York City, we have people from around the world. And so that's been very helpful to test and see how good our interpretation, our variant interpretation ability is. And that's been, it takes us more time, I'll say, to interpret the variants, and we have more variants to spend time on for people that are not white or not of European ancestry. That's been a good exercise for us. The majority of people decide, 92, 93% decide to do everything. That is these optional modules as well, but a few less if individuals consent in Spanish. And that's, of course, fine with me, but it is interesting to watch and see what people differentially choose. We also look at people who decline to understand what their reasons are. And for the most part, people just aren't interested. They are sort of busy with a new baby. They're not interested in research, period. But importantly, it's not specifically concerns about genetic research or about privacy of genetic information. There are a few, but the vast majority, and again, this is out of 15,000 people who enrolled, and then comparably about 27% of those who decline. It's mostly not, these are small numbers, not about genetic privacy. These are the results. About 3.3% of individuals receive a positive screen positive result. I've broken these down with group 1 at the top and group 2 at the bottom. So you'll see that the vast majority are these group 1 actionable conditions. And I've color coded these. Those in red are false positives. So we do have some false positives. And in light pink, there's one block of that I'll just show you as an example. This is for cystic fibrosis or CFTR, that within the first 1,000, we realized that there were 2 variants in cis that we didn't know were in cis at the beginning, that once we realized that, those are false positives because they're one single haplotype rather than being in trans and showing us that they were a genotype together to increase the risk of cystic fibrosis. These are only carriers. And so I bring this up as a point that as we learn this and other information about either phasing, or we have biochemical evidence to say that certain variants are in fact not disease associated, we can then take them out of the pipeline for return further. And so we've been decreasing the false positive rate over time and improving the specificity of the test results that we return. I'm also showing you here that there are a large number of the positives in group 1 that are G6PD. That's the most common. That's an excellent condition. It's our most common condition that's return positive. And of course, we have more males than females because it is X-linked. And so one question that we and others are always considering is this something to return? If it is, when we do this operationally in the future newborn screening, how do we do this in an efficient and effective way? Because it is a significant volume. I've broken this down into 3 types of categories, and I'll go relatively quickly through this. These are conditions that are included in regular newborn screening. We do this in parallel, and we blind ourselves to these results to test ourselves and see how well we do with interpretation, variant interpretation. I'll get to this a little bit later, but the answer is we do extremely well with the interpretation of the variants, and in fact enhance regular newborn screening, because regular newborn screening, just like any screen, does miss some results. Let me go into a little more detail with some of those. This is G6PD, as I explained before. Important to see in the lower left, this is something that we see mostly in non-European individuals. So of these results, again, the vast majority are males, but we do have 31 females who are positive from this, and most of these come from our Black, Hispanic, or Asian patients. And so this is mostly not a European ancestry group. Showing on the lower right, for those of you who really want to think about this, we do have correlation. There are WHO data that correlate genotype with phenotype from an enzymatic activity. We do know that of our patients who have had problems with hemolytic anemia, most of those are in the level or in the group with the class A or the lowest level of enzymatic activity. It's a minority of the individuals. And one possibility is to think about, if you didn't want to return all of these results, if you wanted to minimize the burden, where's the greatest yield? And clearly that would be in the class A. Interestingly, there is a protocol in place for returning G6PD in New York for regular newborn screening. And I won't go into the details for lack of time, but that's at the level of control of the hospital, not at the state newborn screening program. And just to show that system really is not working effectively to identify all the babies, because less than 10%, only 8.5% of those babies were in fact identified through the regular screening protocol that's in place. The vast majority are missed. And so therefore, if the goal was really to screen for all of these babies, we'd need to do something that I think is not at the locus of control of the individual hospital, but really at the level of the system. This is an example of one of the babies who was intended to be picked up by the state newborn screening program for SCID. SCID is currently performed by a TREC assay, or a T-cell receptor excision circle assay, performed on the regular newborn screen dried blood spot. Like I said, no screen is perfect. In this particular case, by sequencing, we included the IL-2RG gene, and by sequencing, this child was found to have a missense mutation that was known to be pathogenic. This is an X-linked condition, and this is a male baby. After we did the family history, we found there was no family history of SCID, and when we tested the parents, that was obvious because this was a de novo variant in this child. We convened a national group of experts in severe combined immunodeficiency. We searched the literature for other cases with this same genotype, and there were 2 cases. One child died at the age of 16. The other child had a life-threatening infection at the age of 1 and was treated with a hematopoietic stem cell transplant. Based on that literature and with the expertise of that committee, their recommendation was to, number 1, test for the functional assay for PSAT5, and that activation assay showed that there was a functional problem in this child, who was lymphopenic as well. During this whole period, I will say we had him in isolation to prevent infections, and their recommendation from that panel was to do a stem cell transplant, ideally within the first 100 days of life, and without any serious infection when that is most successful. So that's in fact what we did. He was successfully transplanted with a sibling donor, and he continues to thrive and has never had a serious infection. And he in fact has now a younger sibling who does not have this condition nor any other condition, was screened with Guardian, and the baby sibling is doing fine as well. So I'm switching now to group 1 conditions, but that are not included within standard newborn screening. So this was really the intent to expand newborn screening. And I'll go quickly through to show you some other examples. This is one example of a baby we've screened for retinoblastoma. We don't have many cancer conditions, but we do have a few. This is one of 2. With this cancer condition, the most immediate concern is for retinoblastoma in the eye. We returned these results at 5 weeks of age and brought the baby in for screening under anesthesia. And at 6 weeks of age, when we did that, we already saw a total of 8 tumors, 3 in one eye, 5 in the other. We were able to cryoablate those immediately in the operating room and were able to save vision and to start chemotherapy. We did that, as I said, very, very quickly. We've brought the baby back subsequently. This baby is still under treatment. We brought this baby back subsequently and identified additional tumors. We've been able to treat those and again save vision. So this baby is still currently undergoing therapy, but shows you that we were able to intervene quite early. And our hope long term is that this will be something that will save this child's vision and, of course, save the child from cancer long term. And again, this was a de novo mutation, so we wouldn't have had any family history to guide or suggest this type of treatment or surveillance for this child otherwise. This is another child diagnosed with Batten disease, and with this particular condition, we had 2 variants with phasing showed that these were in trans, and then we're able to biochemically confirm with enzyme activity that was clearly outside the normal range. With this, we do have a treatment for this condition. We do have an FDA-approved treatment for Batten disease, which is a neurological neurodegenerative condition. We are able to do enzyme replacement where we have to do enzyme replacement directly into the brain. So we've inserted a reservoir where we can then do treatment every 2 weeks. This will be lifelong treatment at this point, but it is something that we can use to be able to prevent long-term neurological deficits in neurodegeneration. And so, again, this is one of these cases where the intervention is not trivial, but in doing this, we believe will be life-saving and obviously the quality of life, I hope, significantly improving. This is another similar case, in this case with metachromatic leukodystrophy. This child homozygous for a truncating variant. These parents actually were identified by carrier screening prenatally, but declined prenatal diagnosis. We identified this child after birth and confirmed the diagnosis enzymatically with a deficiency of aryl sulfatase A. There is just recently now FDA-approved treatment for gene replacement for MLD, and this patient is receiving gene replacement therapy. So again, not a simple intervention, but something hopefully pre-symptomatically that will be disease altering for this child. A more common condition, and again, those are all single patients with those diseases because they're rare conditions. This is, on the other hand, a more common condition. This is long QT syndrome. We currently are seeing that approximately 1 in 800 babies born are screening positive for this. This is one of our little patients who gets the screening, the confirmatory test that we do, which is an EKG. We've actually found that this is remarkably a good workflow. And what do I mean by good workflow? EKGs are available really at many, many different sites, so we can get an EKG literally the same day. This is very helpful for families who may have anxiety about what these results mean. We can get an immediate readout from the EKG. We can have pediatric cardiac electrophysiologists who are able to help us interpret those EKGs if there's any question and send that to them in real time. And so that turnaround time to get from when we call families with these results to be able to get a confirmatory test result can be very quick, even within 24 hours. And that QT interval from the EKG actually helps us quantitatively to assess risk. So it's not just simply a yes, no, but gives us some idea of the severity or the concern. So in doing this, we've had 100% compliance with parents actually following through on those screening confirmations. Within this, we've then based on the QT interval, been able to help decide how aggressive to be in terms of interventions. The simple intervention is simply avoiding medications that will further prolong that QT interval. And that's very simple to implement, and parents are very happy to do that. The next level up is to start a beta blocker. That's an inexpensive, well-tolerated medication. Thankfully, the majority of patients have not needed that, but we've been able to do that when it's necessary, and that's been very well tolerated. And the other benefit is for parents, is that for many, this condition is inherited. And so we've been able to identify parents as well as sometimes siblings and genetically, and then confirm based on EKG. And some of those family members have needed interventions. And we've even identified family histories where there's been a sudden unexpected death. But of course, we don't know whether this was sudden death due to long QT syndrome, but that's been helpful in a cascade way of genetic testing for other family members. Let me quickly go through the group 2 conditions, and I won't go through in lots of detail, but to say that this is one example for Rett-like syndrome, CDKL5 associated with seizures. This result was returned at a month of age, coincident with when this child had their first grand mal seizure. This information was helpful to be able to confirm that this was going to be a lifelong problem, not just simply a one-time febrile seizure or a one-time event. And so medication was started and early intervention as well for this child. So within this, I know this group thinks about variant interpretation, and I'll very quickly go through this. We've also done a study to think about scalability, and is there another alternative pipeline that might be more scalable that would require less intensive variance analysis? And so we've thought about automated pipelines that, for instance, might not have variants of uncertain significance, and wondered what would we lose if we did that. It certainly would allow for scalability, but what would be the opportunity loss in doing this, and thinking about trade-offs. And I'm not saying there's one right answer. I think every healthcare system will have to make their own decisions. And the more that you understand variance in your population, those trade-offs and the weights vary by population. So in doing this, we had an alternative pipeline, as I said, where we simply had an automated workflow where we actually didn't have people in the loop in doing this. And doing this was really about thinking about what we had with databases, disease databases, ClinVar in particular, to be able to help support variance interpretation. And again, as ClinVar is populated better with more information from around the world with variants, the more robust such an alternative pipeline would be. The bottom line is that there are trade-offs with the alternative pipeline. And I'll also say we did this as a quality control measure to see if there was anything that our very resource intensive pipeline missed, because no pipeline is perfect. And as we did this, we realized that our original pipeline did miss some diagnoses. As I said, nothing is perfect. And we also realized that a pipeline that was quite automated also missed diagnoses and missed some potentially important diagnoses in terms of treatability. So within this, I think we're always trying to improve the quality of our pipelines. We've used the information to understand the original pipeline that was run by GeneDx, where they had some holes and some gaps, and to be able to fill those gaps and to change what they were doing, as well as I said, if one were to think about an automated workflow, understand the limitations if laboratories were to use that automated workflow. So for anyone who's interested, these are the sort of gory details about, from an informatic point of view, what we did, both in terms of screening out for common variants, what were done in part with internal GeneDx databases to be able to exclude individuals who are homozygous in internal databases, and what we did in terms of missense variants, which are obviously some of the ones that are more difficult to interpret. The bottom line is, as I said, when we think about this, the vast majority of variants were identified by both pipelines. So within this, there was a lot of concordance, but what did we leave behind? So what did we miss in the new analysis that was picked up by the original analysis? Some important, potentially important diagnoses. Wilson's disease as one, SCID. It's actually a different case of SCID than I told you about previously, this one with an ADA1 deficiency, but an important case of potentially severe combined immunodeficiency. And then the thyroid dyshormonogenesis. One could argue regular newborn screening picks up hypothyroidism, so that might not be the most important one. And then another case of G6PD. So within this, a balance, but to realize that there are some important missed opportunities if you miss this. You can make your own decision about whether or not, those are acceptable in terms of the time that it takes. And so that balance of the resources required and what you leave behind. As we do this, we also look at the outcome. So we follow up the babies from a medical point of view, as well as seeing how their families are doing. And we do this both in terms of surveys, talking to families, and then doing focus groups. We do this 30 days after birth and then annually every year on their birthday. As we do this, I'll say that we've been learning and things change over time. So the bottom line in doing this is that there is always an acute reaction to new genetic information. And I'd say that's true either with the screening test, or it's also true when you make genetic diagnoses, even when patients are symptomatic. There's always this adjustment period. And so that happens acutely, especially within the first month of life. And then there's a process of accommodation or getting used to the information. So we ask parents about their understanding of the information. And the good news about this is that parents really do understand the results. We've parsed this into many different segments to understand, is there any subpopulation where we might need to improve what we're doing? Because we're constantly looking at our data to try and improve the processes. Now, although overall families are doing well, we did identify a very small subgroup, specifically those who speak Cantonese or Mandarin, but are Chinese ancestry, but speaking another language, where there was less understanding. Still good, but a little bit less. And so we've been working very hard with the whole team, especially the pediatricians, to help reinforce the message for that group that may need a few more passes at understanding the information to operationalize it for their child. We've also looked at decision regret over time. Decision regret is in the negative. We've also looked at positive impact on families, but specifically to see, is there any problem? A regret less than 25 is not concerning. And these results, we're looking at them in the acute phase. And so we do see overall on the left, really screen negative, screen positive, overall not a problem. But we were segmenting it with any particular group that might have any issues. Again, trying to weed out and figure out, is there an area where we can improve? Group 1 on the left, no problems. These are positive results on the right. Group 1 on the left of those, no concerns really. Group 2, a little bit more concern, and this is again in the acute phase. So we looked at them and have followed them over time. And so on the left are showing results immediately after return, and then on the right at a year after the birthday, so a year of life. And what you'll see in particular, as we segmented that group 2, where there was some concern, how that's coming down, that decision regret is coming down over time, almost to a level, basically, again, 25 being a threshold for me not to have concern, a level where, again, there's no concern, showing, as I alluded to, that there's an adjustment and they're adjusting over time. And in particular for these families with rare diseases, and again, it's only the group 2 where there was some concern. What they've done, what we've been learning from them, is that they plug into the rare disease group. So they're able to connect oftentimes online and Facebook or other social media groups to parents of these rare diseases. And they're actually learning from other families, and they found those learnings to be helpful. And they've also realized that that diagnostic odyssey can really be quite difficult. And I think many of them appreciate more over time what benefit they've had from being able to get to that diagnosis very quickly and effectively and learn from the other families without feeling like they had to go through oftentimes years awaiting a diagnosis. And so, again, I'm not saying we're perfect, and we constantly learn from our families about how to improve, but this has been quite helpful. So let me just wrap up by saying that within all of this, We still, I think, are learning, but we clearly have found that this is something that families want. It's something feasible to do. We can do the variance interpretation. We can confirm diagnoses, and we can onboard these children to care. And as we're doing this, we are increasing the number of conditions that we feel we have capacity and capability of doing this effectively so that we can help more people. And we're continuing to learn how to support families through this journey. We've added people beyond our geneticists, genetic counselors, and pediatrician, added family navigators, social workers to be able to help guide them through this process and make sure they can access the care that they need to, and continued to educate patient advocacy groups in terms of how to support families from their end, subspecialists to understand how it's different when you ascertain someone from screening as opposed to diagnosis, and really trying to help also the therapeutic community to understand how to help us support families accessing the care they need in a quick and efficient manner. So really developing this entire ecosystem going forward. I'll just say finally that if anyone's interested in delving deeper, we have a paper that came out in JAMA as one of JAMA's top 10 papers last year that talks about this in much greater detail. So I'll finally just thank all the members of the team that make all of this possible and be glad to pause here for questions.
So once again, thank you, Dr. Wendy. We do not have any more questions, but you have shared with us the entire vision as well as the science behind it, and we really appreciate the time that you've taken.